Dear audience, I welcome you to another educational session regarding our international educational series. And today our topic of discussion is about cortical visual impairment in children, one of the leading cause of decreased vision in pediatrics in children. Today we will discuss about it, what are different causes, how these things can be investigated, and what are the possible interventions which can be done. In order to discuss, we have requested and invited an international scholar from Nepal. I'm talking about Professor Srijana Adhikari. She is Professor and Chief of Hospital Services of Pediatric Ophthalmology in Tilganga Eye Institute, Kathmandu, Nepal. She has more than 2 decades of experience in management of pediatric eye diseases. She did her fellowship in pediatric ophthalmology and strabismus from Storm Eye Institute, Medical University of South Carolina. She has also done PhD in global health from Amsterdam, Holland. She has got extensive experience in the management of congenital cataracts, strabismus, retinopathy of prematurity, and we are very fortunate that she has accepted our invitation to guide and educate our audience about this very challenging topic. Cortical visual blindness and impairment is a really challenge, how to manage and how to examine all these things. So without further delay, I will request her to please present her talk. Yes, Professor.
Thank you very much, Doctor, for inviting me for this educational series. And I will be talking today on cortical visual impairment in children, how it occurs and what are the management possibilities, how we can rehabilitate the children. So, thank you very much for the opportunity to share my views on this topic, which is very, very important in pediatric age group. So now I will be sharing my slide. So cortical visual impairment in children. There is no financial disclosure and conflict of interest for this presentation. So what is cortical visual impairment? Cortical, or we also call it cerebral visual impairment. It is a disorder that is characterized by visual deficits resulting from damage to the visual pathways in the brain that are posterior to the lateral geniculate body, including visual processing areas. So it's a leading cause of visual impairment in children in the developed countries, but it is an emerging cause of childhood visual impairment in the developing world because there is an increase in the survival of children with the neurological deficits. There is an advances in the management of ocular diseases and decrease in the prevalence of avoidable diseases like vitamin A deficiency. So previously, it used to be corneal scars or vitamin A deficiencies developing world, but these days the cortical visual impairment has been a leading cause of visual impairment in children. So what is cortical visual impairment? The CVI working group has defined cortical visual impairment in 5 different categories, in which the cortical visual impairment CVI encompasses a spectrum of visual impairments which is caused by an underlying brain abnormalities that affects the development of visual processing pathways and is characterized by deficit in visual function and as well as functional vision. And another, number 2, is visual dysfunction in CVI is greater than expected by any comorbid ocular conditions alone. The visual dysfunctions in the CVI may manifest as a lower order or the higher order afferent visual deficits or both, leading to characteristics behavior in affected individuals. And although CVI may be comorbid with other neurodevelopmental disorders, the CVI is not primarily a disorder of language, learning, or social communications. And the underlying neurological insults of the developing brain may go unrecognized or undiagnosed until later in life. That can also be possible. So these are the working definitions devised by the CVI working group. Now, what is the physiology behind the cortical visual impairment? Whenever we talk about the sense of sight is a complex series of processes consisting of sensation followed by integrations of these sensory informations into the higher cortical centers. So what happens? The sensations or the lower order functions are visual acuity, visual field studies, contrast sensitivity, stereopsis, color vision. So these processes occur in the occipital lobe cortex. And then the integrated or higher order visual functions, when the sensory information is transmitted to the cortices in the temporal, parietal, or frontal lobes, then the higher order visual functions occurs like motion perceptions, visual memory, target acquisitions with the slow and fast eye movements, separations of the figures from the background, and other integrated visual functions. So these are the visual activities, and the cortical visual impairment can be the dysfunctions of any of these visual functions to disease posterior to the because of the disease posterior to the lateral geniculate body. So whenever we talk about the cortical system, what happens is that the visual processing occurs in the cerebral cortex, as we all know that. So there are, and after the cerebral cortex, the visual cortex to the parietal lobe and visual cortex to the temporal lobe, the transmission occurs. And the one is called dorsal stream, in which the where is the objects, and then the spatial perceptions occurs. And another is the ventral stream to the visual cortex to the temporal lobe, where what that is object recognitions occurs. So these are the main two pathways apart from the primary visual cortex in which the visual integration occurs. So any of these pathways, if it is impaired, then occurs the cortical visual impairment. So another entity that is also very important that we have to know is that the delayed visual maturation, which can also result from a temporary dysfunction of the higher cortical centers. So many children have delayed milestones of motor and sensory development. So it sometimes it may confused with the cortical visual impairment. So all these visual processes that occurs, but that occurs in a delayed format, that is a delayed visual maturation. But the cortical visual impairment that occurs because of the some diseases or entity or the causes which I will describe later that causes the CVI. So these are the different things that we have to understand, and these are the visual integration systems in which if something occurs in these systems, then the cortical visual impairment results. So etiology. Now, what are the conditions that causes these visual integration or visual pathways to have a impaired function? So these are the conditions or the dysfunctions of the brain-based visual pathways that may causes the CVI, like vascular, for example, hypoxic or ischemic events in the and the perinatal stroke. For example, if the delayed crying occurs, if the seizure disorders, in these conditions, there is a hypoxic event occurs in the brain, and then that causes the damage to the visual cortex. And infections like meningitis, encephalitis, or intrauterine infections, inflammatory like vasculitis, periventricular leukomalacia, which is very, very important cause, trauma like traumatic brain injury or second baby syndrome, metabolic like neonatal hypoglycemia, mitochondrial diseases, lysosomal disorders, and neurological diseases like seizures, hydrocephalus. These are the etiology that causes the damage to the visual system. And the comorbidities. Now, whenever we talk about cortical visual impairment, there are always, almost all of the time, the many comorbidities can occur, like cerebral palsy, intellectual disabilities, developmental delays, other motor functions delays, sensorineural hearing loss, microcephaly, neurodevelopmental disorders such as autism spectrum disorders. So these are also all the comorbidities that can occur along with the cortical visual impairment. And differential diagnosis always is, just like I said, delayed visual maturation, and there is another entity which is the hereditary retinal dystrophies, in which also fundus looks normal, but the child cannot see properly. So these are the differential diagnoses, but of course the causes of the CVIs are very distinct and different, and we can easily rule out by some examinations. Now, what are the characteristics of the cortical visual impairment? In infants or the smaller children, there can be variable, poor, or atypical response to stimuli, eccentric viewing, there is visual latency, preference to the familiar objects, light gazing, color preferences, difficulty with complex patterns, and preference for certain visual fields, and better visual performance with the movement. If the moving objects are there, they have the better visual response. So these are the some characteristics that occur in children with the CVI in the infants. But in older children, there are some characteristics like slow and inefficient visual performance, deficiency of visual perception and integration, contrast sensitivity impairment, difficulty with complexities, short visual attention, poor visual memory, and difficulty with object recognition or face recognition, and the delay in the expression, visual expression. So these are some of the characteristics that can occur in the older children. Now, based on the area of the damage, just like I explained, based on the area of the damage of the brain, if there is periventricular leukomalacia, especially in optic radiations, the inferior visual field defect can occur. If the occipital lobe, then visual acuity, visual field, color vision, contrast sensitivity, these are hampered. And if the ventral stream area is damaged, then the recognition of shape, color, face. And if the dorsal stream, that is towards the parietal lobe, then there is a where is the object that is that is impaired, direction of the movement, field defect, and gaze abnormalities. And if there is a frontal lobe defect, then the delay in the response of the visual informations that can occur. So these are some of the things that occur in the CVI based on the damage of the part of the brain that is affected. Now, these are the pathophysiology, how the CVI occurs, how we define the CVI, these are the things. Now, how should we approach the patient whenever they come to us, the approach to patient with the CVI? And of course, it starts with the history like antenatal, perinatal, postnatal history, family history, systemic illness, developmental milestones, visual behavior. So all these has to be asked. And systemic examination, of course, is very, very important to rule out any other systemic syndromes or abnormalities. And in this case, the role of pediatrician for us ophthalmologists is very, very important. And ocular examination that we carry out are the visual acuity, pupillary reactions, anterior and posterior segment examinations, alignment and motility tests, and refraction. Of course, the cycloplegic refraction should be done. And in other functions of the ocular examinations are accommodative amplitudes, which may be decreased in these children with the cortical visual impairment, fixation preference or visually guided behaviors, the visual latency, saccades, pursuits, contrast sensitivity. So these are some of the important ocular examination that should be carried out in children with the CVI. And visual impairment, of course, whenever we talk about the cerebral visual impairment, the vision is very, very important and we have to examine the various aspects of the visual functions. Like the visual impairment can be as severe as no light perception to the normal visual acuity in CVI. And the vernier acuity is more affected than the grating acuity. Reduced contrast sensitivity is there. The refractive error, especially hypermetropia, can be there, and that leads to accommodative dysfunctions. Sometimes infantile exotropia can also be there. And of course, optic atrophy can be associated with CVI sometimes because of the hypoxic injury to the optic nerve or secondary optic atrophy due to hydrocephalus. Now, there are other entities apart from vision, the visual field defects, inferior field defects, homonymous hemianopia can be there. The visually evoked potential and EEGs are very important things that help us in diagnosing the supportive investigations, and also the prognosis monitoring and color vision. Color vision, of course, is slightly better than the form vision. And visual recovery. Sometimes in CVI children, some degree of visual recovery is seen in some of the children. The improvement is gradual over months, but however, the exact mechanism is not clear, the visual recovery mechanism. So these are the things that we have to investigate, and of course MRI is very, very important. In the MRI, to establish the diagnosis of cortical visual impairment, in MRI there can be the diffuse cerebral atrophy by occipital lobe infarctions, periventricular leukomalacia, cerebral dysgenesis, parieto-occipital and parasagittal watershed infarctions. So these are the findings that can have, we can see through the MRI. Now, after investigations and examinations and investigations, whenever we establish the diagnosis of CVI, then next step, which is one of the most important thing in management, is the rehabilitation part starts. So rehabilitations of the children with the CVI, it is a multidisciplinary approach in which parents, family, primary care physician, pediatric ophthalmologist or neurologist, educational specialist, teachers of visually impaired and hearing impaired children, physical therapist, speech therapist. So this is a multidisciplinary approach of all these specialists is required for the rehabilitation. Now, what are the rehabilitation goals for the children with the CVI? It needs to be specific and aimed at individual requirement associated with the developmental issues. So whether there is global developmental delayed cognitive impairment is present or not, we have to find out, because most of the children have cognitive impairment in CVI, and early intervention and reassessment is very, very important. Treatment of the systemic diseases is also very important. Refractive corrections, treatment of the accommodative insufficiencies, amblyopia management, strabismus corrections, and treatment of the associated other ocular diseases are very important. So whatever things that we can treat, we have to treat, like refractive errors and all those things. And so for those things that we cannot treat, then we can provide the visual rehabilitation for in these children. So how we do rehabilitate the children? First of all, we have to find out in which category the CVI, in which severity the CVI children falls into. So there are certain the 10 points of the CVI, which is called the CVI range, in which these are the things that occurs, like color preferences, need for the movement, visual latency, visual field preferences, the need for light, difficulty with the distance viewing, atypical visual reflex responses, difficulty with the visual novelty, absence of visual guided reach, and difficulty with the visual environment and visual arrays and recognition of faces. So these are the 10 points that is called CVI range, and according to these points, whether the child has any of these, we categorize the CVI into three different phases. One is phase 1, phase 2, and phase 3. So these phases is the period in the resolution of CVI that indicates the degree or severity of CVI, and these phases are very much useful in planning for appropriate interventions and environmental accommodations. So there is whenever for rehabilitation of the CVI, the following two things are important: the individual educational plan and individual family service plan is important. So this is the chart that shows the individual education goals or objectives of the any child with the CVI. So this chart shows in which phase, according to the points that we examine and then find out in that child, we can categorize child in which phase, like phase 1, or the child is in phase 2, or child is in phase 3. So according to this phase, we can customize the children's rehabilitation program. Like if the child has color preferences and objects are viewed are generally a single color objects, and in the if the color preferences has the favorite color, then the child comes into the range of 3 to 4, or objects may have 2 or 3 favored colors. If the child has, then 5 to 6. So according to that, so another one also, need for movement, visual latency. So all those 10 points that I described, so these are the points and which guide us to find out in which category of the in which phase the child belongs to. So in this way, we can individually we can plan for the rehabilitation of that child. And the phase 1 indicates a severe impact on visual functioning, the phase 2 is moderate impact, and the phase 3 is close to the typical, that is good good conditions the phase 3 indicates. And there are some questionnaires also, 5 screening questions which the GN Dotton has devised, and this also helps us categorize the children. And 3 of the 5 questions, if it is positive, then this suggestive of CVI. For example, difficulty in walking the downstairs, not seeing things that are moving fast as small as animals, not seeing something pointed out in distance, and despite of having adequate visual acuity, difficulty in finding items in the pile of clothing, and difficulty copying words in pictures. So these are the screening questions which can help us find out, even with the good visual acuity children, can find out that the children are having a cortical visual impairment. So these are another set of things that help us diagnosing and help us categorizing those children, and then customize the rehabilitation goal for these children. So now, how do we work in the different phases of the children, in different children in the different phase? Like in phase 1, if they are, this is the severe phase, and in which the children who are given the visual rehabilitation should be in a simple environment with a decreased lighting and noise. Present a toy that is one color and has some movement. Induce a toy in a variety of visual fields and give the child time to respond. And wearing a black shirt and having them on a plain blanket to decrease the complexity. So I would like to, my video is not playing. Oh. I'm sorry, the video is not playing. So I wanted to play the video of the child, which so in the phase 2, okay. So in phase 2, they use the same color object in a variety of familiar places, or use a couple of colors, and need movement and the object of shiny. They might still have a visual field preferences and be slower in responding. And in phase 2, the children might be able to tolerate people talking around them when they are not stressed or tired, and have a child crawl towards a red ball and put it into a yellow container. And in phase 3, it's a little bit better stage, in which we can child now can play objects of the different colors, but might have difficulty with objects with a lot of detail. So their preferred color can be used to help attention in a complex environment. Placing red or color tape around their bedroom door when trying navigate their wheelchair through the doorway might still need movement or shininess of the object for the distance viewing, and can tolerate more noise around them and need someone to describe consistent features of the object. So these are the features that we can give children according the visual rehabilitation according to the phases. Now the take-home message: the children with the CVI and other special needs have associated global developmental delay, delayed sensory and motor milestones of development, cerebral palsy, or autism. These disorders have spectrum of manifestations from mild to very severe. Rehabilitation needs should be assessed for each child individually, and a multidisciplinary approach is important in visual rehabilitation, making most out of their ability in these differently abled children. So these are some of the videos in my hospital CVI unit. We have a different CVI unit in which the children are given assessed at first, and then they are categorized according to the phases, and we give them individualized rehabilitations. So so I wanted to play the video, but because of some reason I'm not sure what is happening. It's not playing the video. So the older children, they are given a different kind of the rehabilitations in these children. So this is my hospital CVI unit. So thank you so much for your kind attention. And this is my hospital, Tilganga Institute of Ophthalmology, in which I work. It's in Kathmandu, Nepal. Thank you very much.
Thank you very much, Prof. Srijana. It was a very interesting talk, and you pointed out something very important about CVIs and the phases and how can these things be handled. Because I know as an ophthalmologist, this area is very challenging to manage and examine and diagnose and proper phasing, really challenging. But your guidelines that you mentioned will be very helpful in the management of this problem. So one thing that is coming to my mind is about you mentioned about dorsal stream and ventral stream. If the child has a perfect or near perfect vision, even then how these dorsal stream or ventral stream affect the vision.
Yes, thank you for the question. So, what happens is that in CVI, the vision can be normal, but the other areas that may be affected are the parietal lobe or the occipital lobe. So, depending upon which area is involved, the child can have field defects, the inferior field defects, or the child have difficulty in spatial, like the space orientation where the objects are, that can be there, or the child have difficulty in vision is okay, but child can have difficulty in appreciating the moving object. So these are, we have seen many children, we think that the child is having a good vision, so there will not be a problem, but still there are certain things that the parents tell us, that the child cannot walk properly or cannot respond certain things in the classroom. He responds a little delayed response. So these are the things that we should keep in mind while assessing the CVI children. So these are the dorsal stream and the ventral stream, whichever according to the symptoms that we can localize these problems in the CVI children, and we can give rehabilitation according to that. Like for example, if the child is having movement problem, motion problem, so then if we detect that, and then the exercises, the rehabilitation exercises mostly are focused on those targets, the moving targets, and we present those moving targets to the child and give the repeated game, like give the game like patterns for the rehabilitation. So in this way we do the rehabilitation. So that is why it is very, very important.
Well, Prof, you also mentioned about CVI range. How the utility of CVI range differ from diffuse tensor imaging when we are managing or evaluating the patients with the cortical vision impairment?
Okay, so this DTI, this is the MRI feature, which is a latest feature in the MRI, which gives us, like in CVI, generally we do MRI and find out some infarcts or anything in the lesion, but the DTI technique gives us more detail about which area has been affected, like whether it's a dorsal stream. That also helps to identify the lobes, the different lobes like dorsal stream, ventral stream in more detail. So that way we can find out, even with the MRI finding, we can see that if there is a damage in certain areas in the MRI, then we can categorize the child in that category, and we also correlate that MRI finding with the symptoms of the child. But the 10 points are those points in which that also helps us, that is very popular, and that helps if we see those 10 points, and what are the points that the child is having, and that also helps us categorize. So DTI images, the MRI images, if we have, that is a very good thing, that can also support our clinical examinations and support, and we confidently can say that okay, this child falls into this category, and according to that we can set the rehabilitation goal for that particular child.
Right, right. Well, we talked about the different phases, phase one, phase two, and phase three. And you also mentioned about these ranges, standardized tools which you recommend for evaluation of function vision in children with CVI, standardized tools, something like that.
Yeah, the tools that the individual education plan that I mentioned, that is very, very easy and important tool that will help us categorize the children in these. And there is another also tools like the tools that helps in assessing the visual functions. So there are different visual functions categories in which we can use the Leah symbols, the Leah puzzles, and so many other things that has different functions. And with the help of those tools, we can identify different the children in a different categories, like visual functional vision is impaired or not, in which stage of the functional vision, and then color or contrast sensitivity like Leah paddle, Leah mailbox. So there are different tools that are available which are very, very useful in categorizing the visual functions. And of course, the phases will help us categorize in which severity the child falls, and then in using these tools, we can very easily customize the rehabilitation program for the children.
Right. Well, Prof, you explained in quite detail about this, as I mentioned, very challenging field, particularly for the physicians, and of course, it needs a team effort by pediatric ophthalmologists, optometrists, occupational therapists, even pediatricians, and most important, ultimately, the parents have to contribute a lot. But even then, so much vision can still be rehabilitated. Uh,
Yes.
Still, we are in the process of evolution in medicine, but still, in spite of our limitations, we can still do and manage and rehabilitate vision. And you have very rightly pointed out that it needs a team effort. Well, it was an interesting topic, and it was a pleasure attending your lecture, Prof. It was very beneficial, and I hope it will be very beneficial for our virtual audience all around the world. And I want to thank you on the behalf of them that you accepted our invitation to guide and educate over them on this very challenging field. Thank you, Prof. Silja.
Thank you. Thank you so much.